Hello and welcome to today's lecture on management of hypertension. I am Dr. Emorinken and I'm excited to walk you through the principles, practical approaches, and guideline-based treatment strategies that are vital in managing hypertension effectively. This is ClinMed Compass, your path to medical excellence. Hypertension is a leading cause of cardiovascular morbidity and mortality. Its proper management helps prevent severe outcomes like stroke, heart failure, myocardial infarction, and chronic kidney disease. In this session, we will focus strictly on evidence-based strategies, from lifestyle changes to pharmacological treatment, special populations, and emergencies. By the end of this lecture, you should be able to understand treatment principles and goals, apply lifestyle interventions that lower blood pressure, select appropriate drug therapies, know treatment targets for different patients, and manage resistant hypertension and hypertensive crises effectively. Our treatment goals are simple but critical: to lower overall cardiovascular risk and mortality, to prevent or delay damage to the heart, brain, kidneys, and eyes, which are the target organs, to achieve and maintain blood pressure targets with less than 130/80 millimeters of mercury for high-risk patients and less than 140/90 millimeters of mercury for low-risk patients. Ensure long-term adherence and improve quality of life. Now we look at the general principles of management. Hypertension management must be individualized. We don't just treat numbers, we treat the patient. Focus on risk-based strategies and organ protection. Accurate blood pressure measurement is crucial. Educate patients and encourage adherence. Escalate treatment stepwise, from monotherapy to specialist referral when needed. Start by stratifying cardiovascular risk into low, moderate, high, and very high. Consider age, smoking, diabetes, dyslipidemia, chronic kidney disease, and target organ damages. Initiate treatment if the blood pressure is 140/90 millimeters of mercury and above in low-risk patients. Also, when the blood pressure is 130/80 millimeters of mercury and above in high-risk group. The SPRINT trial supports lowering blood pressure to systolic less than 120 millimeters of mercury in high-risk individuals. However, in the ACCORD trial, the benefits of tight BP control in diabetes patients is still being debated. Now we'll talk about the non-pharmacologic management of hypertension. We'll be starting with lifestyle modifications. Lifestyle changes are foundation of the management of hypertension. They should accompany pharmacologic therapy, and they are first line in low-risk stage 1 hypertension, in pre-hypertension, and they act as adjuncts in all other cases. Now we look at the dietary intervention, the DASH diet, dietary approaches to stop hypertension. This is a diet that is high in fruits, whole grains, vegetables, lean protein, and low-fat dairy. They are low in sodium, red meat, sugary drinks, saturated fats, and cholesterol. The DASH diet reduces systolic blood pressure by up to 11 millimeters of mercury in some studies. Sodium restriction. Sodium intake should be less than 2 grams per day, and we should avoid processed foods, canned soups, pickles, and salty snacks because of their high sodium content. Potassium-rich foods should be encouraged. Increase potassium intake with foods like bananas, oranges, spinach, and sweet potatoes. Potassium helps to relax the blood vessels and excrete sodium. Weight reduction. Aim for a body mass index of less than 25 kilograms per meter squared. Even a 5 to 10% weight loss significantly reduces the blood pressure. The waist circumference goals for men to be less than 90 centimeters and women less than 85 centimeters. Physical activity: at least 150 minutes per week of moderate aerobic exercise. Add resistance training 2 to 3 times per week. Exercises like brisk walking, cycling, swimming are excellent options. Alcohol limitation: for men, at most 2 drinks per day. For women, at most 1 drink per day. 1 drink is about 14 grams of ethanol. Smoking cessation: nicotine causes vasoconstriction, raises the blood pressure and heart rate, increases the risk of stroke, coronary artery diseases, and peripheral vascular disease. Behavioral counseling is recommended, and pharmacotherapy using nicotine replacement and varenicline are useful. Next is stress management. Chronic stress increases blood pressure through the activation of the sympathetic nervous system. Relaxation therapy are important to reduce stress. Yoga, meditation, mindfulness. Also useful is cognitive behavioral therapy and adequate sleep to be ensured. Now let us move to drug therapy. Start medications in this situation. 1. When the blood pressure is 140/90 and above in low risk to moderate risk patients after 3 months of lifestyle changes. 2. When the blood pressure is 130/80 millimeters of mercury and above in high risk patients, especially those with diabetes, chronic kidney disease, and those with a 10-year atherosclerotic cardiovascular risk of more than 10%. 3. When the blood pressure is 160/100 millimeters of mercury and above, initiate drug therapy immediately alongside lifestyle changes. Other scenarios where you must initiate drug therapy include the presence of target organ damage, secondary hypertension, in pregnancy, and even in hypertensive emergencies. It is important to state that in elderly patients, therapy must be individualized. Different guidelines vary slightly in when to start therapy in patients. The JNC8, the European Society of Cardiology, and the NICE guidelines recommend starting therapy at 140/90 and above. However, the American College of Cardiology guidelines suggest greater than 130/80 in high-risk individuals. It is important to state that the NICE guideline and the ASC guidelines follow a risk-based approach. Always consider the patient's overall risk, not just the blood pressure numbers. General approach to pharmacotherapy in management of hypertension. Start with monotherapy in stage 1 hypertension with low risk. Combination therapy for stage 2 or high-risk patients. The key points to consider include: choose drugs based on patients' comorbidities. Most patients will need 2 or more agents to manage their hypertension. Begin with low doses to minimize side effects. I will now look at the drug classes of antihypertensive agents. The first we'll consider are diuretics. Diuretics include thiazide-type diuretics, hydrochlorothiazide, clothalidone, indapamide. These drugs actually inhibit sodium reabsorption in the distal tube. Clothalidone is preferred for longer action and better outcomes. Side effects include hypokalemia, hyperuricemia, and insulin resistance. They are useful in the elderly, the Black patients, and those with isolated systolic hypertension. It is important to avoid in hypokalemia, in those with gout, and those with hyponatremia. The loop diuretics like furosemide, torsemide, and bumetanide are reserved for patients with chronic kidney disease or heart failure. Potassium-sparing diuretics like amiloride and triamterene are often combined with thiazide to reduce potassium loss. Calcium channel blockers. They block calcium ion influx in vascular smooth muscles. They include the dihydropyridines like amlodipine, felodipine, nifedipine, and they act as potent vasodilators. The non-dihydropyridines like verapamil and the thiazine, they lower heart rate and contractility. Common side effects include peripheral edema, headache, and constipation. The non-dihydropyridines will also cause bradycardia. They are indicated in Black patients, elderly, and those with angina. Contraindications include heart failure and atrioventricular block. The angiotensin converting enzyme inhibitors. They block the conversion of angiotensin 1 to angiotensin 2. They include lisinopril, enalapril, ramipril, perindopril, and others. They are great for patients with diabetes, chronic kidney disease, heart failure, and post-myocardial infarction. Contraindicated in pregnancy and bilateral renal artery stenosis, hyperkalemia also. Watch out for cough, angioedema, and renal dysfunction. The angiotensin 2 receptor blockers, ARBs. They block angiotensin 2 receptor. Examples are the losartan, valsartan, temisartan, candesartan. They are useful in patients intolerant to angiotensin converting enzyme inhibitors. They have similar benefits with less cough or angioedema. Same contraindication as ACE inhibitors, avoid in pregnancy or bilateral renal artery stenosis. Next are beta blockers. They could be cardioselective, as in atenolol, bisoprolol, metoprolol. You have the non-selective beta blockers, propranolol, nadolol. Then those that block both alpha and beta receptor, carvedilol, labetalol. They are indicated in ischemic heart diseases, post-myocardial infarction, arrhythmias. Avoid this drug in bronchial asthma, chronic obstructive pulmonary disease, bradycardia, and peripheral vascular disease. Side effects include bradycardia, bronchospasm, and hypoglycemic unawareness. Next are alpha blockers like doxazosin, prazosin, terazosin. They are useful in patients with benign prostatic hyperplasia or resistant hypertension. Watch out for orthostatic hypotension. Then we have the centrally acting alpha-2 agonists like alpha-metidopa, which is safe in pregnancy, clonidine, which is used in resistant hypertension or hypertensive urgency. Common side effects include sedation, dry mouth, and rebound hypertension on withdrawal. Next are direct vasodilators like hydralazine, used in pregnancy and heart failure, minoxidil, that is reserved for resistant hypertension. It causes fluid retention and hirsutism. Then the renin inhibitors. Aliskiren directly inhibits renin. Avoid combining with ACE inhibitors or ARBs in diabetics due to the risk of renal dysfunction. Number 10 is the mineralocorticoid receptor antagonist. Examples are spironolactone and eplerenone. They are very effective in resistant hypertension. Monitor for hyperkalemia and gynecomastia. For initial therapy, start with monotherapy in low-risk stage 1 patients. Use combination therapy for stage 2 or high-risk individuals. Tailor treatment to the patient's profile and comorbidities. Start low and go slow to minimize side effects. For preferred therapy in Blacks, consider thiazide diuretics or the calcium channel blockers. For chronic kidney disease, the ACE inhibitors or the ARB, same with diabetes patients. For heart failure, ACE inhibitors, beta blockers, the mineralocorticoid antagonists and diuretics are useful. For post-myocardial infarction, beta blockers or the ACE inhibitors could be combined. For pregnancy, safe drugs include metidopa, labetalol, and nifedipine. Combination therapy. When do we initiate combination therapy in the management of hypertension? In stage 2 hypertension, blood pressure above 160 over 100 millimeters of mercury. When the blood pressure is above 20 millimeters of mercury systolic and above 10 millimeters of mercury diastolic, above the target blood pressure. High cardiovascular risk as in diabetes, chronic kidney disease, and established cardiovascular disease. The presence of target organ damage and failure of monotherapy to achieve blood pressure control. The preferred drug combinations are the ACE inhibitors or ARBs plus the calcium channel blockers, the ACE inhibitors or ARBs plus thiazide diuretic, calcium channel blockers plus thiazide diuretics. It is important to state that we should avoid using ACE inhibitors and ARBs together. They increase the risk of renal impairment and hyperkalemia. Fixed dose combination improve compliance and reduce pill burden. Resistant hypertension. Resistant hypertension is defined as a blood pressure that remains above target 140 over 90 meters of mercury, despite the use of 3 drugs from different classes, including a diuretic, at optimal doses. Alternatively, when blood pressure is controlled only with 4 or more medications. First rule is to rule out pseudo-resistance, like non-adherence, white coat hypertension, poor technique, and inadequate regimen. If true resistance is confirmed, add a 4th agent like spironolactone, which is the preferred choice. If not tolerated, doxazosine or clonidine are useful. Minoxidil can be used as last resort in refractory cases. Refer to a hypertension specialist for further evaluation and management if need be. Hypertensive crisis, emergency and urgency. Hypertensive emergency is severe blood pressure elevation with target organ damage like encephalopathy, stroke, aortic dissection, pulmonary edema, myocardial infarction, acute kidney injury. The goal here in treatment is to reduce the mean arterial pressure by 25% in the first hour. The mean arterial blood pressure is calculated by adding the diastolic blood pressure to 1/3 of pulse pressure. Pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. Hypertensive emergency require immediate blood pressure reduction with parenteral medications in the intensive care unit. Examples of medication used include labetalol, nicardipine, sodium nitroprusside, clevidipine, hydralazine, enalaprilat, esmolol, to mention but a few. On the other hand, hypertensive urgency is a severe BP elevation without target organ damage. The goal here is to treat with oral agents over 24 to 48 hours. Stepwise management of hypertension. The NICE 2023 guideline outlines a clear stepwise treatment pattern for hypertension. Step 1. If the patient aged less than 55 years or any age with type 2 diabetes mellitus, start angiotensin converting enzyme inhibitors or the angiotensin receptor blockers. If the age is above 55 years or a Black African or an African Caribbean, start calcium channel blockers. Step 2. If the blood pressure remains uncontrolled, combine ACE inhibitors or ARBs with calcium channel blockers. Alternatively, you can combine ACE inhibitors or ARBs with a diuretic, or a calcium channel blocker with a diuretic. If blood pressure remains uncontrolled, we move to step 3, which is a triple therapy. Combine ACE inhibitors or ARBs with calcium channel blockers and thiazide-like diuretic like indapamide or clothalidone. If the blood pressure still remains uncontrolled with triple therapy, add low-dose spironolactone if the potassium level is 4.5 millimoles per liter and below, or use alpha blockers or beta blockers if the potassium level is above 4.5 millimoles per liter. Seek expert advice if BP remains high despite optimal doses of the 4 drugs. This table compares blood pressure targets across major guidelines. For example, the American College of Cardiology guideline for the general population, target is less than 130/80. Even in high-risk patients, it's also less than 130/80. For the European Society of Cardiology, the target is less than 140/90. However, in high-risk patients, it's less than 130/80. For the NICE guideline, target is 140/90 and below. For the World Health Organization and the JNC8, they have similar targets of less than 140/90. The target for elderly patients are individualized based on the guidelines. The important thing here is that always individualize targets based on age, the risk, and tolerability. Practical approach in clinical practice. Start with a universal target of less than 140/90. For high-risk patients like those with chronic kidney disease, diabetes mellitus, stroke, or coronary artery disease, aim for less than 130/80 millimeters of mercury. In elderly patients, avoid aggressive lowering of the blood pressure. Key things to remember as regards blood pressure target in management of hypertension. Ensure target in most patients of less than 140/90 millimeters of mercury. In high-risk patients, the target should be less than 130/80 millimeters of mercury if it is tolerated. Individualized therapy based on age, comorbidities, and frailty. Avoid excessive lowering, especially in the elderly or those that are frail. Monitor for symptoms like dizziness or falls in them. Always prioritize safety and tolerability over aggressive control. Long-term adherence is more important than quick BP reductions. Now we'll take a look at some special populations. 1. The elderly. Reduce blood pressure gradually to avoid orthostatic hypotension. Aim for a systolic blood pressure of about 130/140 millimeters of mercury if it is well tolerated. Avoid excessive diuresis and polypharmacy. For diabetes mellitus, aim for a blood pressure target of less than 130/80 millimeters of mercury. Use the renin-angiotensin-aldosterone system blockers like the ACE inhibitors or the ARBs for renal protection. Monitor renal function and serum potassium closely. Chronic kidney disease. The renin-angiotensin-aldosterone system blockers are preferred for nephroprotection. They are to be used cautiously in advanced chronic kidney disease. Thiazide diuretics are less effective in advanced chronic kidney disease with estimated GFR less than 30 mL per minute. Switch to loop diuretics in this situation. Regularly monitor estimated GFR and serum electrolytes in persons with chronic kidney disease. Pregnancy. Safe drugs in pregnancy include alpha-methyldopa, nifedipine, labetalol. Avoid the following in pregnancy: ACE inhibitors or ARBs. They are teratogenic. Direct renin inhibitors like aliskiren. Thiazide diuretics because they cause oligohydramnios. In suspected secondary hypertension, You identify and treat the underlying cause, like renal artery stenosis, primary hyperaldosteronism, Cushing syndrome, pheochromocytoma. You manage the blood pressure with appropriate drugs tailored to the condition. After starting treatment, monitor the blood pressure every 2 to 4 weeks initially. Once stable, every 3 to 6 months. Check the labs, electrolytes, renal function, lipids, fasting glucose, and ECG. Reinforce adherence, adjust medications as needed. Consider home or ambulatory blood pressure monitoring for better accuracy. Lifestyle reinforcement is important at every visit. Promising advancements include renal denervation. This is the catheter-based ablation of renal sympathetic nerves for resistant hypertension. Digital health tools like apps and wearables, they help to monitor blood pressure and improve adherence. Novel drugs like endothelin antagonists and vasopeptidase inhibitor. Precision medicine, this helps to tailor therapy based on genetic profile. Now let's summarize the key points. Lifestyle modification is essential. Never ignore it. Tailor pharmacotherapy to individual risks and comorbidities. Most patients need combination therapy. Watch out for resistance, emergencies, and special cases. Prioritize long-term adherence and follow-up, and educate patients as this improves outcomes. Thank you for staying with me through this comprehensive session on the management of hypertension. If you found this video helpful, please subscribe, like, and share. Stay connected with ClinMed Compass, your path to medical excellence.